Welcome to Frame by Frame, Rethink Imaging, a podcast by Immulogics. Here, we explore the intricate world of medical imaging, aiming to dissect the field and inspire both professionals and curious minds alike. I'm your host, Chris St. John. Today on Frame by Frame, Rethink Imaging, we are thrilled to welcome Dr. Kalpana Kanal, a renowned expert in diagnostic medical physics. Dr. Kanal has made significant contributions to the field of medical physics, especially in CT. She was involved first as vice chair and then as chair of the American College of Radiology's CT Dose Index Registry, a key initiative in tracking and optimizing radiation exposure. After she became the American Board of Radiology's Diagnostic Medical Physics trustee in 2017, she stepped back from the DIR. Dr. Kanal has continued to focus her research particularly in areas of radiation safety and imaging advancements, and recently established an imaging physics residency program at her institution. Today, we'll discuss her involvement with the DIR and her current research focus, as well as the future of medical imaging. Welcome, Dr. Kanal.
Thank you, Chris. Nice to be here.
It's so good to have you here. Dr. Kanal, your career has spanned a wide range of research and clinical areas within medical physics, especially related to radiation safety and imaging. What initially drew you to this field, and how did your journey evolve to focus on diagnostic imaging?
Yeah, that's a great question, Chris. So I came to the U.S. in 1989 to do a master's in pure physics. And as I was getting done with that, I realized that my personality is not suited for sitting in a lab and doing, bench research. I'm more a people's person, and I was trying to look for other opportunities that can use my background education in physics. And someone told me about a radiological sciences graduate program, PhD program at UT Health Science Center, San Antonio. And so I checked that out and I decided, this looks really interesting with the medical aspect of physics. And that's how I got involved and enrolled in the PhD program over there. While I was there, I was really interested in becoming a therapy physicist. But my research project for my PhD was actually with the diagnostic imaging physicist, Dr. Gary Fullerton at UT Health Science Center, San Antonio. And that's where my journey with diagnostic imaging started, because I spent all my research for my PhD in that field. And then I got both certified in diagnostic medical physics. So that's led me to where I am today.
Amazing. And so, not to dive straight into the Dose Index Registry, but we're going to dive straight into the Dose Index Registry. So you were the vice chair and then chair of the Dose Index Registry. For those listeners who are less familiar, a pivotal tool for tracking and optimizing radiation doses. How did you get involved with the registry, and what was your role?
Really good question. Again, as any young early career physicist, we look up to our mentors and our senior colleagues to get involved in committees and organizations. Dr. Rick Morin, who's a very well-known medical physicist, retired now, actually invited me to be part of the Dose Index Registry. So I started out with him being chair and part of the committee and, shadowed him in that committee. And when he rotated off, he asked if I would become the chair of that committee. So that's how I got involved. I was invited by another very well-known medical physicist, and that's where my journey began in the ACR Dose Index Registry.
Yeah, and can you just give a little bit of a background on, should I use the word program? How should we even classify it?
Yeah, it is the American College of Radiology Dose Index Registry program. You could call it program, absolutely. It's for CT. And what it is basically, it's actually a really cool thing. They introduced that, if I remember correctly, somewhere around, 2004 or 5. But basically, the registry came out and it was a way for hospitals, small community hospitals, private practices to enroll in it and send your doses to the ACR with all your PHI information taken out, and where you had the opportunity to look how you did with respect to your peers. So it's really a registry of doses from various organizations, small hospitals, big hospitals, and you classify what type of hospital you are, and you can compare your doses to that other hospital, similar types of hospital, and see, are you in the same range of doses as your peers? And are you too high? Are you too low? Or are you fine? And I think it's a good way to assess that with an outside organization, right? So you're sending your data, and it was relatively financially feasible, not very expensive. And that's how I got involved too. We became one of the first sites, we were part of the first sites that as soon as ACR was introduced, we enrolled our program to send our doses to the Dose Index Registry.
Very nice. Yeah, it's funny. I can't remember who I was talking to recently, but I was talking to somebody and they were like, oh, there aren't like fully standardized doses for all CT procedures. And like, no, definitely not. But it's like, it is so cool to, see the origins of, people sharing all of this information and progressing. And so given your extensive experience with the Dose Index Registry, or I'm just going to say DIR for the rest of this, what do you think has been, the impact of the registry on dose management in clinical practice?
Oh, I think it's been significant. As I said, that any hospital or small community hospital, private practice can enroll in DIR. It's not a very big financial burden. It's quite affordable. And if you have not been doing dose management at your facility, this is one way to get started and see where you stand. It gives you reports anytime now. I mean, when I started, it was not a live interactive tool. But now if you go online, it's a live interactive tool. You can look at your doses at any time. You can compare it to other facilities. I think it's a great tool to have at your disposal if you do not have a full, really expensive dose management software available at your hospital. The other thing is that's different about the DIR. It lets you compare your doses with facilities across the country. Unlike your own management tool, just only looks at your facility. So I think it's a really good, useful tool to participate in and see how you're doing. I think it has had a big impact, especially in the United States, because there was nothing like that before DIR. So having some resource to collect data from across the country and then establish guidelines and establish landmarks or benchmarks for doses would be great, right? So the impact was that based on all the data in the DIR, we published 2 very impactful publications. One was looking at top 10 CT protocols in the nation for adult patients and then top 10 for pediatric patients. And I think giving that dose estimate or benchmark. And remember, it's not really a dose. I should be very careful here. It's not really dose to a patient because you're looking at CTDI, which is more like a dose to a phantom. But you're also looking at SSD, which is size-specific dose index, which could be looked at to be one step closer to being dosed to patients. And so for hospitals that have never done dose monitoring, this was one way of getting involved and checking how they're doing and then adjusting their protocols up or down depending whether they were, lower in dose compared to their peers or higher in dose compared to their peers. So I would say that the DIR has had a significant impact on the nation in terms of dose monitoring and establishing benchmarks.
Yeah. And so my understanding, and correct me if I'm wrong, is like the DIR aggregates data from, you said it's just CT, right?
It's just CT.
But from all these different healthcare facilities, were there any challenges about the standardization of that data across different institutions?
Absolutely. So the way this works is when you enroll in the DIR, you have to go to the process of what's called mapping. So what is the head CT protocol at University of Washington, which is my institute, versus, the head CT protocol at MGH on the East Coast, How do we make sure that we are talking about the same protocol, right? So you have to map it to some common terminology within the DIR to make sure you're comparing apples to apples. So that is a very challenging process depending how many protocols you have. And I know DIR is continually working on making that process easy. So I think that initially for us was a challenge trying to just map all our protocols. So if you have that right, then you're comparing apples to apples. But then the other thing the DIR can do is the only information you can get is whatever is on the DICOM header. So some of the challenges or questions I got when I was a chair was, why are we not looking at doses as a function of scanners that have modern dose reducing software like using iterative reconstruction or AI reconstruction or more modern scanners compared to old scanners? Well, if it's not available in the DICOM header, the Dose Index Registry cannot really tease out that data. That was one of, I think, the most common complaints I got when I was a chair of that program. So I think there are challenges in doing this. And even when we did our papers, there's challenges in curating the data. You want to make sure your data is clean. There is no contamination with, combo exams or the mapping not being done correctly. I think the one thing the DIR is relying on facilities is to do the mapping. They are not looking at what mapping you're doing. You're doing the mapping and they are not looking at our image quality. So you're sending the dose, but they have no idea what your image quality is because we are not sending them any images. So I assume your next question would be, what is one of the drawbacks? And I kind of already talking about that.
You can get ahead of me. Go for it. I love that.
Right. So since we're already talking about this, it's great to have the doses, but I don't know that routine head CT at University of Washington versus the routine head CT I picked on MGH is what is our image quality? Even though our doses might be comparable, what is my image quality? What tools am I using? What scanners am I using? So that definitely would be the other side of the coin. You cannot look at dose without looking at image quality. And that's something the DIR didn't have at that time, right? And I still don't think we send any images and look at image quality. We only look at dose. But I think that is something that would make sense if you could look at both sides of the coin and then look at dose and compare it to the image quality. So I think there are some drawbacks, but I still would encourage anyone who does not have a dose monitoring software at their institution. This is a really easy way to participate and get involved and monitor your doses.
Yeah, absolutely. And regarding image quality, right, with the new CMS clinical quality measure coming up, I think outpatient is going to be required in 2027. So at some point, everybody's going to start looking at their image quality versus their dose quite a bit, I feel like.
So yeah, there is that CMS requirement. And I know that the Dose Index Registry is probably going to figure out how to incorporate that or come up with a solution with their current platform. And then sites who have dose management software are also, I think the vendors have already started looking at trying to implement that in their software. So yeah, it's coming. We'll see what happens.
Yeah, we absolutely will. So can we talk a little bit about those two research papers? I believe you were focused on establishing diagnostic reference levels or DRLs and achievable doses for both adult and pediatric CT using DIR data. How did the DIR contribute to ensuring dose benchmarks were accurate and, clinically useful?
So when we had enough data in the database, right, then we said, okay, now it's time to start thinking about establishing some benchmarks from all this data we have across the country. So for the adult population, we looked at about 1.3 million exams, I think it was, if I'm not mistaken. And for the peds, I think it was about 1.5. So what we started doing is, okay, let's start with the adult, right? So we have all this data that's sitting in our database. Let's establish a benchmarks. What is a typical dose that the facilities, like-minded facilities, are seeing across the country? And what are our top 10 exams? So we started working with the DIR. I think the data curation took us probably a year. I was working with my other physicist who at that time was still working for the American College of Radiology, Miss Priscilla Butler. And so we started working with the DIR and saying, okay, this is how we want to frame the paper. Send us some data. And so the data curation went on. Is this clean data? Do we see anything else? Do we need to drop some of these combo type of studies and things like that? That took us about a year. And then we managed to get a really good statistics on the data too, right? No data is good without good statistics. And Dr. Ihsan Seme was involved. Dr. Frush was involved in the pediatric paper. Some are very well-known radiologists and physicists. And after that data curation period, and the analysis, we had a lot of help from the ACR statisticians and staff. Ms. Butler and I started writing the paper with the help of our colleagues. And we said, okay, after that paper was established, the adult paper, now you had a resource that was built, that established benchmarks built on a really large number of data. The more data you have, the less is your standard deviation. So the more solid, right, the data is. And so that benchmark was the first time in the United States that we established benchmarks for the top 10 exams in the country. And I thought that was great because now any site can look at their CT head or CT abdomen or, chest exam and compare it with these benchmarks and see how they're doing. That's a great starting point. I mean, it's a great way to start your dose management. And diagnostic reference levels are basically established at the 75th percentile of your data. And if you exceed that, then you need to look at why is your data high. It really means that most of the facilities can get data less than that, 75th percentile, right? So I think it was a monumental undertaking, but I think the result was so impactful on the population, not only in the US, but outside the US. Anywhere where physicists do dose management, having this resource was extremely useful. So once we got done with the adult paper, then everyone said, hey, what about peds? Because peds are even a more sensitive population. So we took that on after the adult paper and started working on that. But in peds, we also did one step further. We did age and size, because some hospitals look at their protocols as a function of age and some do with size. So we put both of them in the paper to give, ammunition or give people a resource, if you will, to compare their protocols. That took even longer, like the data, because not a lot of people do peds, and we had to definitely get a lot more data to get good statistics. We had some guidelines that we followed when we were taking data for that paper, and those are all established or mentioned in the paper as well. So I think those were very impactful publications. And, even though I'm first author, I cannot take the credit for it. I had a whole team of people, right? The DIR people, other physicists, radiologists. So it really was a village that built this great resource out there. So I think it's time again now for DIR to reestablish DRLs, because it's already been almost 8 years for the adult paper and 4 or 5 years for the pediatric paper.
Yeah, it's so funny to hear from my perspective as someone who didn't even take high school physics. It's so funny to me to hear like peds was only age specific until y'all decided to introduce size as well. I'm a 33-year-old man and I know 15-year-olds who are larger than me.
Right, exactly. And as I said, some hospitals look at their pediatric protocol as a function of age and some look at size. As you said, a 15-year-old might be a 300-pound patient possibly, right? Or a tiny patient. And so you have to adjust your protocols according to the size of the patient, whether it's peds or adult. And I think these are just the starting guidelines, right? Okay, this is what we got from the 1.3 or 1.5 million data points. This is what we are seeing as the DRL, the 75th percentile. In these papers, we also had the achievable dose, which is the 50th percentile. And most people should be in the 50th percentile range, but you're saying, okay, here's your range, 50th percentile to the DRL, 75th percentile. If you're here, you're good. If you're over 75th or closer to the higher range, you may want to look at your protocol. Why are you higher compared to the rest of the facilities who can achieve this target? So I think they were very impactful papers, but I know ACR will probably now look at writing newer, updated papers with more data coming in, because you have to keep looking at this benchmarks over every 3 to 5 years to make sure they remain the same. It's a moving target with new machines coming out, new bells and whistles for reducing dose, AI coming tools now for reconstruction. I think it's time again that they will be looking at that again. I think you're going to be hopefully talking to Dr. McKenney, who's the current chair of the DIR, who can tell you what they're thinking about for future.
I'm curious, what are some of the biggest misconceptions when it comes to DRLs, and how can facilities use them more effectively?
What are some of the misconceptions? I think maybe people understand. I don't even know if there are misconceptions, what you're saying. I think people do need to understand how to calculate them. I think that's important. The methodology is important, and there might be some misunderstanding about the methodology. And people should be following, and I believe it's ICRP 135, I think, which defines the methodology. But so that might be an issue, what DRLs and how they're defined. And just for people to have tools and resources to help them figure it out, right? So if I'm not participating in the Dose Index Registry and I do not have these fancy dose monitoring software, how do I come up with DRLs for my institution, right? So we try to do that a little bit in the paper and in all the presentations I've given since then. Where do you start and how do you establish that? So I think the methodology is important for sites to understand. You could do this with a small number of patients, take your most common exam and do it. So I think in terms of misconception, I think understanding the process is important.
So Can you talk about where some of these smaller facilities should start?
Oh, absolutely. I think a smaller facility that does not have a lot of resources and don't have dose monitoring software, I think the ACR, they could participate in the ACR, but if that's still financially not feasible, I think they can start with their most common exam, right? And monitor 20, 30, 40, 50 patients, look at the CTDI, the DLP, the SSDE, and then do the math, follow the process, which I'm not going to go into detail here, but there is resources out there, right? So, and that's where they could start, right? With one protocol, their most common protocol, start the work. It's manually totally possible in an Excel spreadsheet and see, okay, I did my head CT. Now let's see what my DRL and AD is. And then I can compare it to these papers, right? If they're looking at peds or whether they're looking at adult. There, you got one done. You have an idea. You have a handle on your doses, right? Better than not knowing anything, how your doses are doing. So that's what I would advise small facilities to do. Start small. Take the most common protocol you have and the most impactful that impacts most of your population and start doing this. And once you do that for one, it's easy to extend your range. Pick your top 10 protocols if you like. You don't have to do this for every protocol. And then expand your range. You do it for one facility, then you do it for your second facility, third, how many ever you have. Because then not only is it important that your doses at one hospital are optimized, but that the doses at your other hospitals, if you're managing more than one hospital, are also optimized. So I don't think it's difficult to do because there are many resources out there. ACR itself, the DIR program is such a resource, but there are a lot of papers, there is presentations, NAPM, and so on, where people can find resources. You can talk to your physicist colleagues all over the world. I'm working with one right now in Nigeria to establish DRLs for their doses. Not difficult to do, if you know there are resources out there.
Absolutely. I think that's exactly what I was looking to hear. And yeah, I mean, it's funny. The more and more I do this podcast, the more so many answers feel just close to just like everyday life things, just within the veil of medical physics, right? That first, the journey of getting better at something, just that first tangible step, right? There's a silly kids cartoon that I love where somebody says sucking at something is the first step to being amazing at something. And I'm not saying people are terrible with their doses, but just like taking that step is like so necessary. I'm trying to learn how to sew. My first thing was like, I want to run a seam. One seam. Okay, I'm done. I did it.
Yeah, and this whole thing started many years ago where all the spotlight came on CT dose because of some high dose cases that were published in newspapers. And that put the whole focus, oh my God, that we are giving cancer to our patients. We're doing this, we're doing that. Well, I wouldn't quite agree with that. I think, maybe our doses were a little all over the place, but I think we've come a long way. I think we are almost guilty now of going the other direction, maybe that we are too low. I think the word to use here is optimize, right? We want to optimize our dose. We don't want to go low. I don't want to go low. I want to do what's best for my patient. That means getting the best image quality I can get at the minimal dose possible. But that doesn't mean that I'm competing with anyone to be the low dose. I want to be an optimized facility, right? And that's what accreditation helps us with ACR, right? They look at our doses, things like that to say, okay, are your protocols okay? But I'm really worried that we might be going the other direction. How low is low? How much money do you want to spend trying to keep going low? So I think the key here is finding balance. Start your first step, get a handle on your doses, optimize them. And one thing I want to say is you may not be able to optimize it for every patient or every protocol because it depends on the need of the radiologist, right? And it depends on what vendor CT machine you have. Is it the old one? Is it the new one? So I think doing the best with keeping the patient in mind, but at the same time, what the radiologist needs, extremely important. We are physicists. We don't review images. The radiologists do. We don't want them missing anything. So I think optimizing the dose and not trying to say, no, you cannot read at this, we're going to lower. No, you have to work with your radiologists. You have to work with your technologists and get that balance where you are confident that your doses are optimized and your radiologist is confident in their diagnosis when they're looking at those images. That is critical.
Yeah, for sure. I've been just surrounded by these conversations more and more these days. I'm like, if I ever get into the CT, crank up the volume. You know what I mean? Like, give me that HD 1080p image quality. Zap me. I want to see everything.
We don't want to do that either, Chris.
I know. I'm teasing. Okay, so after playing such an integral role in DIR's early days, you have since stepped back from the initiative. What kind of led to that decision, and where are you focused now on your research and your professional work?
Yeah, so I got very fortunate to become a trustee, a diagnostic medical physics trustee for the American Board of Radiology. And I had to step back from the ACR because it was really difficult to manage both those leadership positions. The ABR trustee role is pretty demanding of time, but it's a very fulfilling role as well. So I've been doing that since 2017. And that's why I stepped back from DIR. I mean, I'm still involved with ACR. We're still trying to write some papers. I'm very much talked to all the leadership there now as well, but I'm not actively involved. Right now, my focus has been, in terms of work, has been on a very interesting new path that not a lot of people in physics are, which is forensic CT. So what that is basically using CT. So you're leveraging technology to determine cause of death or trauma or whatever is going on in a cadaver. So instead of doing an autopsy, if you could have that cadaver or that dead person go through a CT, and you can figure out what is the cause of death and don't have to cut open the body, that is significant. So I've been working on this for the last 6-7 years. So my chairman, Dr. Dushyant Sahani, when he came to University of Washington and he was talking about some of his far-thinking ideas and his vision, this whole world of forensic CT totally resonated with me. And I just went with it, and he gave me his blessing to move forward with it over here at University of Washington. So we started working on this, and we have scanned about more than 150 cadavers on our Siemens CT scanner. You can do it on any CT. It's just that our Siemens CT scanner is right one floor over our medical examiner's office. And we have scanned 150, 160 of them. And about 45 to 50% of the cases, an autopsy was not needed because the CT gave them the answer to the reason for the cause of death or the trauma or whatever the reason might be. And these are cadavers that come, decedents as well, it's called, from suicide, trauma, accident, natural death, stuff like that. And that has been a fascinating pathway that I have taken. At AAPM, I presented because I want people to be aware of this. In America, here in the US, not a lot of sites do this. But outside America, a lot of sites do it. Japan does it. Australia does it. There's England that does it. And why not here? I mean, just imagine the impact on community if you do not have to cut up a cadaver, right? Think about the cultural and emotional sentiments that people have and saying, my relative suffered enough and now you want to cut them open, right? I wouldn't want that for my relative. So I think it's going to have a far-reaching effect. We are publishing on it right now. It's in the process of being published. I've given several talks at physicist meetings to bring awareness. And the main common question I get is why not, right? Why aren't we doing it more in the US? And I think it is an issue of billing and things like that for anything because radiologists have to read these images. We work pathologists on doing this. So we have established this program here. And we did such a great job of convincing our medical examiner colleagues that we helped them buy a CT scanner, which is going to be installed in the medical examiner's office in a couple of months. And then they're going to have every cadaver go through it. For my project, we did selective, right? Because we didn't have the bandwidth. But now imagine the whole new world opens up. The other reason this is great using technology, but from a ME perspective, there's a shortage of forensic pathologists. So there aren't a lot of people available to do autopsies. They're backed up for days. Using technology to help, why not, right? So this is something I have been very interested in for the last 4-5 years, and that's what I've been working on to establish a forensic program here at University of Washington. Very, very interesting to me.
Can I just ask? I'm so curious. So, I mean, obviously, there's different cadavers coming in, and maybe you have clues of, when it comes to selecting protocols for these cadavers, is it always full body scans? Is it case by case? I'm kind of just curious about how you approach this.
Correct. So we had the same questions when we got started. And I think we have now worked so much in it that it's getting more fine-tuned, that the forensic pathologists who order these CTs from the medical examiner's office actually give us guidelines. They say, we are interested in the pelvic area. So can you just run a pelvic CT? Or we are interested in chest, abdomen, pelvis. Or we are interested in the head. So now we are actually moving away from doing whole body. And that's actually good because the scanner, if you're doing whole body, You're heating up the scanner. You're creating tons of images, which no one is necessarily going to look at. You're bogging down your...
Right. How many slices do you have to go through for a full body scan?
Exactly. A lot. It also depends what slice thickness you're reading at. So we have now actually worked so well with our program and our medical examiner's office that now they give us guidelines. They say, okay, for this cadaver, say it was a car accident. So it's an MVA. We suspect there's trauma in this area. Can you do a CT here? Or we suspect this is going on. There's a lot of conversation going on between the forensic pathologists and our radiologists. They get some guidance. And so we are now more focused in what we do. And we also actually do conferences every other month, I think it is, or every month, where kind of like an M&M conference where we are looking at these cases and we're talking. It's so interesting because you're talking, the radiologist talking, hey, here is the finding on the CT. And then the forensic pathologist is putting their gory images with the blood and gore and anatomy, which now you're used to seeing, and you're trying to correlate the two, right? Which is so fantastic. So they learn a lot from our radiologists, and our radiologists learn a lot from the forensic pathologists. What are their needs? What are they looking for? And I would say we are a good example of the success for someone who's trying to establish the program. As I said, there are other programs. One in Albuquerque, OMI at University of New Mexico is a very well-established program for years. They scan every cadaver that comes over there. So, we are learning from other people, and I think we have been very successful in doing this, and I hope to see more happening in the future. And then you can apply this to education, right? Medical student education. You don't need to cut up bodies to look at anatomy. You can look at images, CT images, and see what it looks like and things like that. So there's a limitless potential for taking this to any other area you want to.
And so I can't help but wonder, with you and your background in dose optimization, now working on forensic CT, so, your past experience with DIR, now working in forensic CT, did you have any observations about dose or image quality that you kind of picked up while working with cadavers?
So the one thing is that dead people images look very different than live people, right? There's no blood flow. And the more further away from death you're imaging, it's going to look different. So I know that the dose is not a concern. They're dead, right? Yeah. So you're not worried about optimizing dose. But at the same time, you're not overexposing them either. We are really focused more on the radiologists and what image quality they want, right? So we haven't really tweaked our protocols because we use automatic tube current modulation. And the radiologists have been happy with it. They haven't told us to tweak anything because, again, it's hard for them anyway to look and relearn what anatomy looks like in a dead person because there's no blood flow and things like that. And that's what they're focused on. They're not focused on dose or anything. So that's not even come up. But we might do some projects with our residents in the near future to look at, all the 150 patients we've done so far. What has been the dose? Curious, right? If there was a 300-pounder or a 100-pound patient, what is our range of doses for these cadavers? And is our radiologists who are reading these are so far seem to be okay with image quality? They haven't told us to increase the dose. So it's a different question. The focus is more on, are we finding what we need to find with the physiological changes in cadavers because they're not alive, more than worrying about dose. So the focus is a little different.
Yeah, I wasn't thinking that you were focused on dose, but I was just curious about, what your approach was when it came to image quality.
Yeah, we took the same clinical protocol and we're using this. We probably tweaked up our dose a little bit because we were not worried about harming anyone. So maybe 10-20%, which is not significant. And so we really haven't deep dived, if you will, into the dose aspect of these 150 or so we have done so far. But that is something we're starting to look at now that our program is getting a little bit more established. We can now start looking at research projects along all these data that we have.
That is way more interesting. I mean, not that it wouldn't be interesting, but you had me just sucked in for a minute.
Yeah, it's been the response I've received at any audience. I've presented this to physicists. I've presented this to technologists. Our paper is getting published in JCAT. It should be coming out soon. I have had that response. This is so interesting. Why don't we do it? Well, yeah, why don't we do it, right, in the US? So it's a question of billing and time and the radiologists getting compensated to read these images.
Yeah, absolutely. Someone performing an autopsy, there's billing and stuff involved in all of that as well. But yeah, no, it's fascinating to hear, and it just makes so much sense.
Totally. That's what I say.
That is beyond fascinating. Dr. Kanal, thank you so much for joining us today on Frame by Frame. It's been an absolute pleasure having you.
Thank you so much, Chris. That was a lot of fun. I didn't even realize that we have a formal podcast going on here. It was like a conversation, so I really enjoyed it. Thank you very much.
Good. Thank you so much. Frame by Frame Rethink Imaging is brought to you by Immunologics. Here, you'll find engaging interviews with thought leaders, experts, and patients, sharing stories that showcase the transformative power of medical imaging. To discover how Immunologics is rethinking imaging in healthcare, visit Immunologics.com. Be sure to subscribe to Frame by Frame Rethink Imaging on Apple Podcasts, Spotify, or wherever you listen. And from all of us here at Immunologics, thanks for tuning in.